Hello there. I thought I would do a quick video today on the blood transfusion issue for folks. I've seen some posts on Reddit now and then about folks that are waking up and starting to get really worried about that they would, at this point, like they would accept a blood transfusion if they really needed one. And so they're worried about if they're unconscious after an accident, and they're worried that their family will refuse the blood transfusion on their behalf and they might die. If they were awake, they would have accepted it. So I thought I would talk a little bit about that from my perspective as a registered nurse. I spent about 8 years in a trauma ICU in a level 2 trauma center. Level 1 is the highest in the US, and so at my hospital, it wasn't really that we were doing much less than what a level 1 would do. It was more just that we were in a more rural area, and we just didn't have the patient volume that a hospital in a major city would have. So I did get to see a lot of trauma patients. And the first thing I want to mention is that there's sort of an idea as a witness that doctors are just itching to give you some blood. You go in to get your flu shot and hey, give this guy a blood transfusion while you're at it. And that is not how it is in the real world. Doctors don't like to give blood. Hospitals and doctors recognize that blood is, for one thing, an expensive resource. It's entirely dependent on how much people donate blood, and then the process is very labor intensive to process the blood, and to get it from a regional blood bank to hospitals. It's just little old retired guys driving around in cars, and they carry the cooler up to the hospital's blood bank. So it's an expensive process to have blood available, and it's a finite resource. Again, it depends entirely on people donating it. And I'd go up to the blood bank at the hospital and to pick up some blood, and the fridge, the cooler where the blood bags are kept, it's a pretty small cooler. There's not a lot of blood in it. So physicians are hesitant to give blood, and even just in the 10 years I've worked as a nurse, I've seen a lot more reluctance among physicians to give blood as the new doctors come out of med school. They are better trained to use it only as a last resort. The second thing I want to mention is that as a the situations that we'll talk about, trauma patients after accidents, they're pretty rare situations. So you don't need to constantly worry about what if situations and hypotheticals that might occur. Trauma patients in general, it's not super common that somebody gets into an accident. And actually, the one good thing as a witness is that to some extent the lifestyle protects you from a lot of the situations that would make a patient end up in the trauma ICU. So for example, probably the number one risk factor to end up in the ICU is alcohol use, getting drunk and then doing something stupid. And for sure, if alcohol use quit overnight, the number of patients in trauma ICUs across the country would, be dropped in half instantly. Alcohol is a huge factor in a lot of accidents. And so, while witnesses may be heavy drinkers, a lot of times they're not getting drunk and then going out and doing stupid things. So, getting drunk and then going driving, or getting drunk and shooting guns, or getting drunk at a bar and getting into a fight with someone. So witnesses are kind of shielded from that aspect of getting hurt. So alcohol. So let me just say, there's maybe three things that are major causes of admission to a trauma ICU. And probably the number one thing is falling after a fall. And so again, once you eliminate alcohol, that eliminates a lot of falls, and so that witnesses are less apt to have that situation. Now, the other end of that is older folks, elderly patients that trip and fall and get hurt. And so that's certainly something that could happen to a witness. The second major cause of admissions to the ICU is probably car crashes. And so again, I would say this is more rare for a witness than the average person. Again, they're not drinking and then driving typically. They're not driving 120 miles an hour just for fun. So they're shielded from a lot of that. Now, on the other end, again, they're susceptible to being hurt by a driver that's drunk or just, wiping out an icy road, that type of thing. The third thing that ends up putting people in the ICU, I would say, I would call it gangbanger stuff. So stabbings and shootings, that type of assault. And the vast majority of that is related to drug activity. So witnesses being generally law-abiding, they're shielded from a lot of that violence of being stabbed or shot. So that being said, I'll talk a little bit about what it's like to come in as a trauma patient. So say you were in a car crash and the ambulance brings you into the ER. I'll say ER, but doctors and nurses in the ER prefer it to be called the emergency department because it's a whole wing of the hospital these days and not just a single room. But anyways, you come into the ER, get wheeled into the trauma bay. All your clothes will be cut off if they're not already, so you'll be there naked under a blanket, hopefully. And the trauma team is going to rapidly assess you from head to toe. And they're really checking for things that are going to kill you in the next few minutes. So you may come in with a broken leg, broken arm, big cut on your head. They really don't care about any of that. They're looking for, are you breathing? Is your heart beating? Is there things that, are you going to bleed out in the next few minutes? What is your blood pressure? And those are really the things that they're obsessing over on their checklists. What they're especially concerned about is looking at things between in your trunk, so say from your neck down to your pelvis, and they're looking at internal injuries, and they're thinking about what might have happened from your car crash or being hit by a car. The forces are so high from those type of things that you're really apt to hurt your internal organs, which could start bleeding, and then you die from blood loss. So their suspicion is really high about internal injuries, and so they're looking at what might have happened in your belly and in your chest. There's a few things they can do in the ER. They can do an ultrasound of your abdomen called a fast exam, and that can kind of show if there's bleeding in your belly. So if that's positive, they'll take you right to surgery to open up your belly and check it out. And then they're looking really at your blood pressure. Is it really low? Is it dropping as you've been there? And again, their threshold for taking a trauma patient to surgery right from the ER is pretty low. They're more apt to do it than not if they have any questions, because the payoff is really big if they do discover some kind of internal injury. And the surgery itself is, you recover pretty well from it, so there's not too many downsides. So if they think that there might be something going on in your belly, they'll wheel you right over to the operating room, which is usually really close to the ER, and they will open up your belly and just physically examine everything in it. They'll look at your kidneys, they'll look at your liver, they'll pick up your intestines and run it inch by inch and just looking for tears or ruptures. And they're really doing damage control at this point. So if your spleen is ruptured and bleeding, they'll take your spleen out. If your kidney's ruptured, they'll take out a kidney. If your intestines are torn, they'll just cut out that part of the intestines. So very aggressive. If your liver's bleeding, they'll slap quick clot bandages, which are gauze infused with clotting factors. And so basically they're working really fast to check everything out there. They'll do the absolute essentials that need to be done, and then they'll cut a big piece of foam. It looks like a sponge basically, and stick that in your belly. Cover the whole thing with like a saran wrap almost. They won't close your belly with stitches. They'll leave it gaping open and hook up a suction hose that goes to a little motor, a little suction canister that will help drain out any fluids in your belly. And they'll ship you over to the ICU at that point. So as far as blood use, if you're coming into the ER and they're giving you blood right off the bat, which they are set up to do, you're in pretty bad shape probably at that point. You're probably unconscious. Your heart may already have stopped from blood loss, and they're doing CPR on you. So what I want to say is, people think sometimes about what if situations about, I'm unconscious and I need blood, but my wife's in the next room over and she's refusing blood on my behalf. That's not very likely to happen. If you're really badly injured, the chances are that everybody else in the car was also really badly injured. And so they're not going to be in so much better shape than you that they are thinking about advocating for refusing blood for you. So I wouldn't really worry about that. If they're deciding to take you right to surgery to explore your belly, the anesthesia team is going to give you all the blood that you need during that surgery. There won't be any questions. The trauma team in the ER, they're not trying to find your wallet to see if you have a medical directive in that. That's not even on their list of tasks to do at that point. So yeah, if you go right to surgery, chances are that your family is not even there yet, and nobody's going to be refusing blood for you. And that's kind of the major point, that you would need blood right when you're first admitted to the hospital in those first hour or two. That initial exploration surgery is a very fast surgery, maybe 45 minutes or an hour, and you'll be in your room in the ICU. So, by the time your family gets there, you kind of be over that initial hurdle. And at that point, most likely the rest of your stay in the hospital, the blood issue is not going to be a life or death matter. At that point, there are a lot of options that the physicians have to handle blood loss. So if you're a medical patient stepping away from the trauma situation a little bit, if you're chronically losing blood for medical reasons, some kind of disease, there's a lot of things they can do. They can do EPO, erythropoietin, or Procrit shots, which can stimulate blood cell production. They can give you iron infusions, which is this crazy black goop that I inject into IV lines. They can give you IV fluids. They can give you albumin infusions. We used to give tons of albumin, which is kind of sort of a blood product. I forget what the society's ruling is on that. So there's a lot of non-blood treatments medically before they would go to a blood transfusion. And then for surgical patients, whether it's a planned surgery like a hip replacement or whatever, or a trauma patient, sure, they could look at giving blood to kind of get you over the hump short term. But ultimately, they need to figure out where the blood loss is coming from and then stop it. So are you bleeding from some kind of wound? Did something reopen in your belly that they need to fix? So the focus isn't really on replacing the blood, it's on fixing the problem so you stop bleeding. So again, it's really only in that first hour or so that the blood thing will be a life or death issue. And again, it's unlikely to come up as a problem, either because your family has also been seriously injured, or they're not there yet by the time you go into surgery. Let's see. So, who can give consent? So say, so you come back to the ICU from your exploratory laparotomy, they call it, the belly exploration. And especially if it's at night, a lot of times the anesthesia team will say, just leave him sedated, unconscious on the ventilator, the breathing machine with the breathing tube in your mouth. Just leave him like that, let him rest till the morning. And in the morning, the team may try and what's called extubate you, which is take out the breathing tube and wake you up. Or a lot of times, I would say more than half the time, what happens with the belly surgery is the initial surgery there is just, like I say, a damage control thing. And they need to go back in within 48 hours to open everything up again and reassess how things look in your belly. And at that point, they can either, sew everything up and you'll be done, or they will do some more repairs, put another sponge in there, a wound vac it's called, and take you back in 2 more days. And that can go on for a long time, a week or two if need be. I forget where I was going with that. But anyways, the point is that blood transfusions are something that need a consent, either from the patient or from their family. And so if you're awake, so if they decide to leave you intubated and sedated, unconscious, you won't be able to, accept or refuse a blood transfusion. Or if you've sustained some kind of head injury, so you're not cognizant and competent to make your own decisions, the medical team will look to your family. And so there's two groups that are legally authorized to make your medical decisions automatically. The one would be your spouse, so your husband or wife is authorized to make decisions for you. And the second case would be if you're a minor, then your parents can speak for you to make medical decisions. Beyond that, it's not as clear cut. So if it's your brother or your aunt or your grandpa or your best friend, the medical team can listen to them and take into consideration what they're saying about what you would like. But they're not authorized to make medical decisions for you. And especially if they're advocating for something kind of wacky, like no blood, something outside of the mainstream, the physicians are probably not going to just roll with that. And if it gets really sticky, hospitals have an ethics committee, which is a group of physicians and social workers that can decide tricky situations. One other group that could make decisions for you is if you filled out some kind of legal document beforehand. So you have a healthcare power of attorney, some kind of proxy person you've authorized to make medical decisions if you're not competent, a living will. Living wills are actually only usually good if you're in a end of life kind of decision. Otherwise, they don't kick in. Um, so in the blood, document that witnesses have would kind of fall into this situation if you've authorized somebody to be your healthcare proponent for you. So so if you're awake, not an issue. You can make your own decisions. If you're unconscious, if you're medically sedated, or again not competent at that point because of a head injury to make your decisions, then yes, your spouse or your parents can make that call for you. And so they may, speaking for you, may say that, hey, he doesn't want a blood transfusion. Again, like I say, once you're over that first couple of hours in the hospital, it's probably not gonna make or break you. You're not gonna die if they refuse blood for you at that point. But it is, a valid issue, and so really, unfortunately, at some point, if you have changed your mind, you used to refuse blood, and now you're of the mindset that, I think I don't really agree with that teaching anymore. I would take blood if I really needed it. That is something at some point you would need to talk to your spouse about to get them on the same page as you. if, So I know it makes it tricky if you're just starting to wake up, but at some point that is a conversation you would need to have with them. And the other issue is if you have filled out a healthcare directive, a no blood directive, you wouldn't, even if you've talked to your wife and she's on board with, yeah, he would take blood if it's life or death, and then an elder shows up with your healthcare proxy from the congregation files that says, and it says, oh, this is his most recent wishes, he definitely would refuse blood. That gets kind of a sticky situation there as well. So you might need to destroy those documents. So again, I know that kind of forces your hand a little bit if you're trying to fade out. But again, I want to stress these are rare situations. So don't burn all your mental energy on hypothetical scenarios. But just to kind of broach the issue a little bit there. So that's kind of my main points I wanted to bring out. Just that physicians are not super eager to give blood anymore. It's actually a hassle to give blood. There's specific numbers on your lab work that the hospital wants to see. And when they're ordering blood in the computer, you have to justify each unit of blood you order. So they're not going to be super eager to give you blood, but it is a tool in the arsenal that's available. And again, rare situations we're talking about here, car crashes and accidents that don't come up, are very rare for most people, and especially for Jehovah's Witnesses. So don't get super stressed about it. And again, the blood issue, as far as being life or death, is typically within the first hour that you're at the hospital. And so either your family is going to be injured as well and not really in a state to refuse blood for you, or you'll already be in surgery and done probably by the time, family and elders show up from the congregation. So it'll be a moot point at that time. And then finally, that who can make decisions for you? Yes, your spouse and your parents legally can. Parents only if you're a minor. As an adult, they wouldn't have the same weight, I would say. So at some point, you may want to talk about that issue as you would want to talk about any end-of-life issues. I think it's always valuable for families to discuss how they feel and what they'd like their family to do, not only about blood, but about, if they sustained a severe head injury, would they want to be kept alive at all costs, despite what the quality of life would be. It's valuable for families to talk about that and have something in their memory that they remember the person saying, just on the off chance that that happens in the future. So I hope that's kind of helpful, and that's just kind of what I wanted to bring out about that today. All right, well, thanks for watching, and take care.